Good afternoon. I'm Leslie Benson. I'm at Boston Children's Hospital. I'm a pediatric neurologist with an interest in AFM, coming from a neuroinflammatory background. And I'm going to talk today about treatment. So my main disclosure is just that there is no approved treatment, and thus all treatments that I potentially talk to in this entire talk are off-label. I don't have any other relevant disclosures. When I think about the treatment, well, when first asked to give a talk about treatment of AFM, not this time, but in the past, my first thought was, well, that'll be short. We don't have anything that is amazingly effective and immediately works. But that's a little, I was a little too facetious. There's actually a lot that we think about when it comes to the treatment of AFM, and a lot that we're learning, and a lot that a lot left to learn. When I think about treatment, I like to think about it in the context of the different phases and the different places for us where we have the potential to treat patients with AFM. And I like this figure from Kevin Messakar's paper, just thinking about the symptoms as well as the findings during different phases of AFM, particularly breaking it into the prodromal illness, the onset of the neurologic weakness, and the late progression of the neurologic weakness, and then the sort of recovery, rehabilitation, convalescent phase of the illness. And thinking about those different phases, I also think about the sort of different buckets of options that I have for my patients. Today, we're really going to focus on acute treatments, with the that being the one that, again, we'll focus on, but it's only a fraction of what we can do for AFM patients. In addition to acute treatments, it's important to think about all the symptomatic and supportive treatments, and those are, as highlighted in the last talk, important in the acute phase, throughout the acute phase, and also into the chronic phase. And then I think similarly, my third bucket is chronic and rehab therapies, which are important fairly early on, as well as for the duration of a rehabilitation phase and even long term. And then a separate category that will be spoken about on a different day in a different symposium is the surgical options, but things like nerve transfers, which are really an option in a relatively narrow period of time, and then muscle and tendon transfers, which may be less time-sensitive options to help optimize patients' function long-term. So honing in on acute treatment, I like to subdivide again and think about what are we targeting, and really there's two targets thus far that have been explored, including immune-directed treatments, and then the second would be antiviral treatments. Those have gotten a lot of attention and use. I think there may be other areas to be thinking about as well, including possibly neuroprotection. So to kind of drill down into immune-directed treatment, this has really predominated thus far, and it makes sense that it's extrapolated from the treatment of autoimmune inflammatory conditions, or particularly transverse myelitis, which AFM has many similarities to. And in 2014, when the first really well-recognized cluster across the United States presented, there was a lot of debate about whether this was a form of immune-mediated transverse myelitis or not. And over time, I think that the use of immune therapy has become somewhat controversial, and there are definitely different schools of thought without a correct known treatment plan that's recommended. And we'll go through a little bit more. Really, I think IVIG is probably the most accepted and is the easiest to kind of agree upon. Then an offshoot of that may be a more directed monoclonal or polyclonal antibody rather than just pooled IVIG. And I think you'll hear more about that in one of the upcoming symposium as well. And then steroids is the mainstay of what I do with neuroimmunology, and certainly those have been used in AFM, and we'll talk more about that a little bit, but we don't really know what the place for steroids is in AFM, and if there is one. I think that's really where most of the controversy lies. And then plasma exchange has also been used. So to give you a sense of how much they've been used, here's another table from Kevin Messakar, looking at 4 different populations. 2 specific centers in the CDC represent the 4 columns. And they looked at many different variables, but this piece of the table that I pulled out is focused on treatment. And I want you to notice that across these different rows, that IVIG was used in about 3/4 of the patients. So sort of the most standard across different populations. Plasmapheresis in less than 1/4, but definitely a significant portion. Steroids was really variable, anywhere from a minority of the patients to a majority of the patients, depending on the population looked at. And antivirals were really minimally utilized in this cohort. When assessed, both centers noted no response to therapy. Sort of the take home, and I think the consensus among many is that AFM doesn't respond to treatments like transverse myelitis, MS, as many of the other more accepted autoimmune conditions do. And then the last thing I want to point out on this table is that the prognosis across the populations was not great. The patients, as is my experience and others, the minority of patients recover fully. This row here notes the proportion of patients that had a persistent motor deficit at the last follow-up. And you see it's the majority, 75 to 95%. Quick break. So next, go through a little bit of overview of what we have tried with viral-directed therapies. So in 2014, both pacapavir and pleconazole were on the market, or at least accessible in at least a compassionate use basis. And there, at the time, were known to have some antiviral activity, and so were considered in 2014. Fortunately, follow-up studies didn't suggest that there was really any anti-enterovirus D68 activity with those medications, and so they really, I don't think they've been used much at all since very early years. Next on my list is fluoxetine. And in 2015, so following the 2014 clusters, Dr. Ken Tyler in Colorado put out a commentary in the New England Journal of Medicine questioning whether fluoxetine may have some enterovirus D68 activity, and thus that was used off-label in 2016 in some patients. And we'll come back to that in a little bit. So, we've used a lot of different things where people have described that use somewhat in the literature, but sort of what's next? And it's clear that we don't have, at this phase of knowledge, we don't have clear treatment algorithms that we know work. And there's, we've talked a lot about how do we change that? And there's a lot of challenges to treatment of AFM. And so I just want to review those a little bit before we delve into how do we get past that and what is the best we can do. So really, when you think about the phases in that initial figure and think about time windows for acute treatment, that time window is likely very, very short. And so trying to pick up the patients, have a timely presentation, timely diagnosis and confirmation, and be able to intervene before irreversible neurologic damage occurs is very challenging in itself. Then we're trying to do this in a rare disease that hits wherever it wants, not in one tertiary care center, and is often being treated in many different ways as well. So different rehab techniques, different supportive measures, and then trying to interpret what effect that therapy had has a lot of big challenges from a trial perspective. So what do we do when the trials are going to be difficult? Before we do that, we rely on basic science. So Dr. Tyler again created the first mouse model, no, there's more than one, of AFM, and showed that enterovirus D68 could create the clinical picture. And I know he's going to speak later in the symposia as well. I don't want to steal his thunder, so I'm going to focus on what his initial studies of treatment showed and simplify it a bit. Basically, he showed that if he gave the mouse IVIG, the mouse did better. If he gave this mouse steroids, and not just a regular mouse doesn't die with steroids, but the AFM mouse died when given steroids. Gave him fluoxetine, didn't really help, didn't really hurt, nothing, and no major effects. And I always got an eye out to see if there's more on the horizon, what else we can trial in the mouse to maybe inform what we can do for our patients. And just to delve a little bit more into the IVIG effect. This is a figure from their paper showing the motor impairment score plotted against the days from infection. So the top line is where they just gave the mouse AFM and no treatment. And so they had the highest level of motor impairment and the worst scores. The next line down, they gave them IVIG. And subsequently a little earlier, little earlier, little earlier. And the bottom line with the X's, they gave the mouse IVIG essentially concurrently with giving them the virus, and prevented the development of AFM. So certainly, at least in a mouse model, there is an effect. There was a definite timing and IVIG effect seen. Now, mice aren't humans, and we can't extrapolate directly. And so there have been attempts to try to learn more about treatment in humans as well. And this was a really huge effort and a well-done study that Kevin Messakar organized with multiple centers, submitting data on the patients that were treated with fluoxetine and those who were not treated with fluoxetine, and trying to compare those two groups. And of course, when you're comparing apples to oranges across the country, it's a hard comparison to do. But they, no matter what the statistical modeling and other things, they really could not pull out a clear, definite beneficial clinical effect from treatment with fluoxetine in the human population studied. So now what? I think there's a lot of interesting basic science coming out that we can go through next, and maybe some more on the horizon for both the immune-directed and the antiviral treatments. So I think we have time to go through a few of the papers that have been put out in 2019 proposing some possible drugs with anti-enterovirus D68 activity. So this one is a drug called telaprevir. It's a medicine used to treat hepatitis C, and it's on the market. It does, in this paper, inhibit enterovirus D68 mechanistically, and is a potential target or potential treatment. There are a few concerns that may make it not necessarily a practical treatment option, but I think there's more to learn and more to consider. We don't know what the CNS penetration of the drug would be. We don't know how early we would have to give it in order for it to be effective, going back to all those concerns on the other slide. And it apparently is a fairly cumbersome medication that has a low barrier to resistance in hepatitis C. And so how that would play into treatment of AFM is not clear. There are, as I understand, new similar inhibitors that are coming out for Hep C, but I'm not aware of any literature related to AFM at this point in time. One other paper that came out was looking at quinoline analogs, and these are kind of early phase studies, but some at least basic science suggestion that they may have activity against enterovirus D68 and the potential for treatment. Like I said, very early phase, and we don't know about CNS penetration, etc. And then the third, another one that I'm aware of, is this capsid binding inhibitor with its drug name R856932 that also has some potential for having anti-antireviral D68 activity, but certainly no human or mouse data related to that yet. And, you know, outside of those buckets, I think there are some other things. So those are the antivirals I know I'm aware of. They're, you know, thinking outside the box and maybe extrapolating a bit from the neuroinflammatory world and the MS world. I've always wondered if there's things that we could do that would be neuroprotective. I think so far this is unexplored, but I think a potential area for further study. I know that families in particular are very interested in the possibility for stem cells, which are entering some human studies in other conditions, but I think it's a complex consideration to think about how that would be interpreted to children with AFM, and I think that's probably a long ways off. And then can't give any talk about acute treatment of AFM and all of these challenges that I've listed without mentioning the possibility of prevention and vaccination. And that is certainly an area of interest and an area of discussion that is ongoing. So thinking about moving forward, I think there's definitely room for clarifying the effect of inflammatory directed treatment, and people hopefully are thinking about ways to look at what data we have and what we know about those and work on the controversy. There's certainly a lot of room for the study of the further antiviral treatments. In our center, we have considered with the mouse model of IVIG and the theoretical benefit of IVIG and anti-EVD68 antibodies within that product, giving it as early as possible and perhaps even the full 2 grams per kilo up front, as they do with Kawasaki's disease. Again, totally off-label, anecdotal, but something that we have thought about here, but has to be weighed against potential risks of things like clotting and hemolysis. And then I think something else that we need to think about in the future are combination therapies, so things that are perhaps immune-targeted treatment along with antiviral treatment, for example. So that's all I have. Next up, as they mentioned in the intro, but for anyone who joined later, we have question and answer session over in the sessions section. So if you look on the left-hand side, there should be a sessions button. If you click there, it will take you to a different page, and there you have to click again on the specific session where we will be doing the question and answer portion.